Hi students, we're going to talk about amputations on this video. We're going to do a quick overview on fractures, so we have two questions. A plaster splint is applied with an elastic bandage to the leg of a patient with a fractured tibia in preparation for open reduction and internal fixation. The patient reports increasing pain in the affected leg and foot that is not relieved by loosening the elastic bandage. The first action by the nurse is to A. Elevate the leg on 2 pillows. B. Notify the healthcare provider. C. Apply an ice bag over the fracture site. D. Perform neurovascular assessment of the foot. So what are we going to do first? And think of what complication we might be worried about here. If you choose D, you are correct. We would be concerned about compartment syndrome, and we need to do a neurovascular assessment and then notify the healthcare provider. We're not going to ice or elevate the extremity because that can further reduce circulation. A patient has a severely sprained ankle from a sports injury. What should the nurse teach the patient prior to discharge? A. Alternate cold and heat for 30 minutes until symptoms are relieved. B. Apply cold for 20 to 30 minutes with breaks of 10 to 15 minutes during the first 2 days. C. Use continuous cold for the first 24 hours and then continuous heat. D. Apply continuous heat to the ankle for the first 24 hours and then continuous cold. So what is the most appropriate? If you choose B, you are correct. We want to apply cold in breaks of about 20 to 30 minutes for the first 2 days. We don't want to do continuous cold or continuous heat. That can damage the tissue. Moving on to amputations. This involves either traumatic or surgical removal of the extremity. Risk factors include peripheral vascular disease, diabetes, trauma, and then thermal injuries, tumors, osteomyelitis, and congenital limb disorders or other potential causes of amputation. Your diagnostic studies are going to focus on the underlying cause. So if infection is a contributing factor to amputation, we're going to get white blood cell count with differential. If we're worried about vascular status, focus on vascular studies. Interprofessionally, we want to assess the general health of the patient, address any infection or chronic illnesses. If the amputation is planned, prepare the patient and caregiver prior to the surgery. And the surgical goal is to preserve as much extremity length and function while still removing the diseased or infected ischemic part of the limb. Preoperatively, consider the reasons for amputation. Is this patient getting any prosthesis? And then mobility training programs, especially if a patient has a lower extremity amputation. Postoperatively, this focuses on residual limb care, bandages, positioning support, and ambulation expectations. Phantom limb sensation, you might also hear it referred to as phantom limb pain. This is where a patient is experiencing pain in the extremity that is no longer there. So say a patient had a AKA and they're saying they have pain in their foot, but their foot's no longer there. They still feel like they have pain, and we'll talk more about that in a minute. Postoperatively, this is going to be patient-specific. If the patient suffered trauma, monitor for PTSD, monitor vital signs, look at the bandage for signs of hemorrhage or infection, and then if the patient needs prosthesis, there's also interventions we'll do for that, which we'll talk more about. If the patient isn't going to need a prosthesis, try to get them a wheelchair so they can still get around. And going back to phantom limb sensation, so this is basically a nerve pain. The nerves are still firing even though they've been severed. It can be acute or chronic, and one thing that we can do to help patients with this is mirror therapy, and this allows visual information to replace the sensory feedback in the brain. So the patient will literally sit in front of a mirror and look at the extremity to help with the phantom pain, but we still want to manage phantom pain because it's very real to the patient. Here we have a patient with bilateral AKAs. who is using prosthesis and getting around just fine. Here's a patient that's undergoing mirror therapy. You can see she has amputation with prosthesis and is engaging in the mirror therapy to help with the phantom limb pain. Rehab, this is really going to focus on physical and occupational therapy. The success of it will depend on physical and emotional health. One complication of amputations are contractures. This can actually delay rehab, so preventing contractures is very important, especially while we want to maintain as much function of that extremity as possible. And then if the patient is going to need a prosthesis, we want to apply the compression bandage and or residual limb shrinker to prepare the limb for the prosthetic device.